Hi everybody, I want to welcome you to our June Talks on Tuesday webinar. My name is Dana Childress and I work with the Integrated Training Collaborative Project at the Partnership for People with Disabilities at VCU. And I am excited to be joining you today for what's actually our last webinar of our season. Our season typically goes from September to June. So we're pretty excited to tackle a topic today that I think will really interest a lot of you, a lot of early interventionists. We love talking about brain development, so you're going to get lots of good information today. So before we start the webinar, I wanted to just take care of a couple of housekeeping things. I wanted to make sure if you're just joining us and weren't able to join the orientation to our tools, to make sure you know that you have access to your chat box. So you'll find your chat box in the lower left-hand corner of your screen. Your chat box allows you to ask questions and make comments as we're moving through the content for the presentation today. So feel free to use that as we're moving through, and we will do our best to capture your questions and answer them as we're moving along. If you type a question and it gets missed and we don't answer it right away, know that I'll be keeping track of questions too, so we'll have a little time at the end to catch up if there's any questions that we missed. We're going to be using a couple of other tools today, so as we get to those points in the presentation, I'll help you walk through those tools, but remember, you always have access to that chat box. Our topic today, as I said, is a really interesting topic. Today we're going to be talking about neurotypical brain development, and we'll also dive into how different it is for children with autism, ADHD, language delay, etc. We'll spend a good bit of our time checking in on thinking about infants and toddlers who either have autism or who we suspect may have autism, and talk about brain development in ways that I think will help you have some understanding about why children do some of the things they do and how they're processing the world. So I'm really happy to have Dr. John Harrington presenting with us today. Dr. Harrington is a physician down in my area here in Tidewater with a lot of expertise in this topic. So I'm actually going to turn things over to Dr. Harrington to introduce himself and to get us started. So go ahead, Dr. Harrington.
Thanks a lot, Dana. Welcome. You know, I'm basically excited and also somewhat nervous because there's a lot of information, to cover related to the brain and autism and learning, but also for all types of developmental delays and stuff like that. And the interesting thing is that early intervention people have such a large role to play in this, that the more you guys understand about the development of the brain, I think the more you can actually be advantageously working, with the kids and stuff and showing changes and improvements in that. So my field is general academic pediatrics. I've been doing this for over 25 years now. I have 3 children, 2 who are neurotypical girls, and they are like 25 and 21 at this point in time. And my son, who has autism, is 23. So I've been sort of traveling the road of autism for the last 21 odd years after my son Sean's diagnosis. So I also work out of CHKD, and I see about 4,000 patients a year. So I still sort of keep an active practice and stuff. So a lot of my understanding of learning and development and autism is actually through practice. But I do have to give a shout out to my wife, because she's the one that sort of taught me most about my son's autism and stuff. So most of the things I've learned through autism have been through my wife, so just so you understand that sort of lens that I'm looking through. But without further ado, we will go into some of the background information that is needed about understanding how the brain functions and stuff. So obviously, cardiac people may confuse this. They usually say the heart is the most important organ, but in reality, the most complex and important organ in your body is your brain. It only weighs less than 3 pounds. So you think about it, most of us weigh over 100 pounds, and like less than 3% of our body weight is functioning, what we do over the regular day and stuff. And it contains billions of neural networks that interact to create our behaviors, our thoughts, our patterns, our feelings, and how we sort of interact with the world. And if you look at the sort of gyri of the brain, which is basically the numerous folds that give its wrinkled appearance, the folding together of the brain tissue allows all of this sort of complex informational gathering tool to fit into our little heads, okay? Approximately 2/3 of the cerebral surface is located in these sulci and sort of valleys that represent the cerebral surface and stuff. So this is a miracle or marvel, if you will, of engineering done by, whatever you believe in and stuff, that all being, sort of decided that this is what your brain is going to look like, this is how we're going to fit it into a small cranium, and then this is how we're going to utilize it over time and stuff. So if you look at the brain in terms of its actual sort of lobes and stuff, you can start sort of putting together the ideas of where things are. So obviously, we're pretty straightforward. The frontal lobe is in the front, right? So most people are pretty familiar with, that sort of aspect. And the frontal lobe is the primary motor cortex, or our premotor cortex. A lot of the things that we sort of decide on how we're going to move, how we're going to do things, but it also, in some of the area of the frontal lobe is Broca's area, where many of you, if you work in early intervention, or this is sort of where there's production of the speech and stuff. Now there's also Wernicke's and things, but we'll go over that in just a little bit. But understanding that the frontal lobe is our personality, our judgment, our reasoning, our problem solving, abstract thinking. Most people believe that the frontal lobe really doesn't fully develop until age 25 in males. Probably females, it's more like 18. No, I'm just kidding. But basically, the reason why that's important is that many people who have things like ADHD or are difficulty in sort of processing and things, usually you don't know their full potential until they're about 25. So the fact that you're taking these kids at age 2 or 3 and they have no ability for impulse control doesn't mean that they won't gain that impulse control. So I think that's a really important aspect and stuff, and also a good reason why males should not marry before age 25. So that's just an insight that I have with my daughters. So I just thought you'd like to know that. I think there's a question now that Dana wanted to sort of go over in terms of giving you guys something to do.
Sure. So we wanted to test your knowledge and see if you guys can pull out of the back of your brains what you might remember from school, from grad school, and see if you can take a guess to tell us where on the brain are Broca's and Wernicke's areas. Now, we wanted you to use your pointer tool to drop a pointer on the slide to let us know. Now, you can only drop one pointer icon, so you might want to pick Broca's or Wernicke's areas to make your best guess. So to access your pointer tool, you're going to look to the left of your slide. There's a vertical toolbar there. The vertical toolbar, the second box from the top, you'll see probably a smiley face or a starburst, whatever tool you might have used earlier. Click on that little icon, and then move your cursor over to the brain and click again to drop that little icon on the picture of the brain to make your guess about where Broca's or Wernicke's areas are. And I see some folks have gotten the hang of that, so we'll let them take a guess or two. Looks like several folks are trying that out. So how did they do, Dr. Harrington?
I would say excellently. It looks like most people have done this area in here, which is exactly, it overlaps the frontal lobe. I don't know if you can see my little hand moving. Just give me a yes on that, Dana, if you do.
Yep.
But in this area right here, and so you guys are all hitting that area, and you can see how integrated the brain is in terms of you don't just have it in one area and stuff. So the Broca's area is here, and since we weren't able to sort of cover Wernicke's, Wernicke's right back here. So most people think about Wernicke's and Broca's being functionally together because they're connected by a tract. So that's an important aspect that I wanted to cover early, that tracts, or the way the brain communicates with itself, is extremely important, and we'll go into that in a little more detail as I go through the rest of the extra parts of the brain, okay? So up next for us is, we'll skip this, is just sort of give you an idea of it. It's kind of flip it around and show it to you again on the Broca's and Wernicke's. But on the parietal lobe, located right behind the frontal lobe, it's our somatosensory cortex. And what does that mean? It's sort of the somatosensory information that comes in is how you remember if something is hot or rough or sharp, and how that sensory feeling is remembered by your brain and stuff. So you can actually know what something feels like before touching it, or you can know what something looks like it's going to feel like before touching it because you have this somatosensory cortex. And believe it or not, the parietal lobe is very important in that area. And so kids with autism tend to have these sensory problems or pressure issues and things like that. And most people feel that this is the area that's affected for spatial orientation, perception, and even comprehension of language and stuff, and recognizing touch. And so I think that's one of the areas, if you're trying to think in terms of frontal lobe sort of is your guiding thing for reasoning and insight and judgment, and then your parietal lobe is really for that sensory or somatosensory information that's coming in on a regular basis to our brains and stuff. Let's go into the next part of the brain. So the temporal lobe. So the temporal lobe is also very important in involved in receiving and processing auditory information and the higher orders of visual information and complex aspects of memory and language. It's also where the Wernicke's area hangs out as well. So again, connecting the tracks and stuff, and they're located, the temporal lobes are located on each side of the brain, obviously, and stuff. And your hearing and understanding of speech and stuff like that comes through this area of the thing. So our next area of the brain, which many of you are familiar, are the occipital lobe. It's the furthest in the back. It's the one that, sort of when you slam the back of your head is the one that gets kind of squished up against the brain. This is your visual processing area. This is where the optic nerves sort of separate into and gives you your visual processing area. Many people believe that kids who have language delay or autism and things like that, that their abilities for visual understanding and visual processing are actually more improved because of the fact that they need that because their language processes are not working as well. Also in the occipital lobe and overlapping is the corpus callosum, which kind of connects the two hemispheres of the brain, and that little fox or cerebral fox that goes across starts there and goes all the way up to the frontal lobe. In the next area, which many people sort of put it as an afterthought, but really the cerebellum, if you want to place in your chat area, if you know what the cerebellum means in Latin, if anyone knows that, they're welcome to answer that in the chat area. But the cerebellum is probably, when we think about it, it's probably the most important area of the brain overall in terms of kind of communication, because 80% of our neurons exist in this area of the brain. It's only 10%. Yes, people of Fairfax has got it and Ira got it, so little brain. So it's actually its own little brain, believe it or not, because it processes all this information that's coming from the larger cerebral cortex. And the cerebellum is considered like the way station that allows the information to come and go. In kids with autism, this tends to be affected, and so the Purkinje cells and the fibers tend to be smaller and stuff. But we believe that there's implicit learning that occurs within the cerebellum that allows kids with autism to piece together things based on what they're seeing and get that in intrinsic logic of what's going on and stuff, but language processing. So if this is absolutely affected, then your ability to understand what's going on in a social conversation gets lost. So a lot of people have started focusing their attention in this area of the brain, and I just want to sort of bring that to your attention because that's where a lot of new information is coming out about language processing and communication difficulties. And this may also be part of our areas where language delays and other areas are sort of affected as well. So I think it's an important area of the brain that gets overlooked sometimes because it's so small, but it is important. So moving forward, we have a little question that we'd like to do a poll on. So which part of the brain is not important in helping with social functioning? Frontal lobe. Oh, sorry.
I was
Go ahead.
Dr. Harrington, just to remind them, you guys can use your pointer tool again, same tool you just used, to drop an icon on the answer. So whichever part of the brain you think fits the answer, or if you think all parts provide some social function, drop your pointer in the black circle. So go ahead, Dr. Harrington. Sorry about that. It looks like the answers are coming in, and people are a lot of consensus on their answer here. How did they do?
They did excellently. I don't really have to sort of go over, but you realize that the brain is so well integrated in its ability to sort of utilize information that all parts of the brain are important for social functioning, as described earlier and stuff. So the occipital lobe, the cerebellum, the temporal lobe, all provide input of information that allows us to figure out the social implication of what is going on around us. So therefore, any area of the brain that is affected can affect your social input and stuff. So that's why, you know, if you talk about ADHD in terms of a neurodevelopmental problem, kids with ADHD have a lot of problems with social functioning because they have no frontal lobe ability for impulsivity. So they just butt in on conversations, or they blurt out answers, or they become, you know, sort of one of those people that you're just sort of like, I do not like spending time in the room with this person because they're so annoying. That is not, you know, a problem that they can necessarily understand well. So therefore, you know, social functioning is affected by each lobe and each area of the brain. So I think a very important aspect when we move into you know, understanding our different aspects of the brain and how they impact our ability to socially function. And I think that's really a key element, you know, from early intervention forward, is that we use language for social functioning. And if you can't use language for social functioning, even if you have great language, you're not going to be able to function well. So I think that's an aspect that we need to sort of, you know, really embolden and emblazon on our sort of abilities to understand that just because a child's speaking doesn't mean that they'll be functioning well. So let's get into sort of some more sort of depths of, you know, we've kind of looked at it from a 30,000-foot view. Let's look more down on the ground, if you will, and, you know, look at the matter. Okay, there's gray matter and white matter. Gray matter is kind of a pinkish gray color in the living brain. This is the actual area where things happen. That has the cell bodies, the dendrites, the axon terminals, and neurons, where information is passed from one neuron to another through the synapses. Then you have the white matter, which is made of axons that connect the different parts of the gray matter to each other, so that this information can move very quickly through the brain. In a matter of, like, you know, thousands of seconds, information can move from one section to the brain to another. They're called the myelin that covers the axon and gives it the white color that you see. I always think of the gray matter and white matter in terms of my kids used to be swimmers, and so that ability to hear the sound of the horn and jump off the swim blocks and stuff. People have different reactions to that, but the fact that you can hear a horn and make your whole body launch itself into the water within a 0.03 second period or 0.02 second period is quite amazing, that we can get our 180-pound bodies to do such a thing. So I think it is sort of a way to think about how this functions. So in our little thing here, we can sort of say, when we're trying to point out the different areas of the matter in the brain, and this is sort of just a CAT scan of that, this is fairly straightforward. Since the fat of the brain is a little bit of a denser material, you can see that this is the white matter that goes on the outside and intrinsically will go and help with neurons and stuff. And then your gray matter, which is a lighter color and stuff, that sort of integrates the neuronal things. Hopefully you can see that on my pointer. I'm not sure if that came through clear enough for you. And obviously this is the skull outside of the brain. So in terms of how that intrinsically works for you, we have lots of myelin sheathing, but there's lots of gray matter also helping along to get those neurons firing. So a neuroatypical brain, how is that different than a neurotypical brain? So this is just sort of a question that is being sent out there. Dana, you want to sort of work them through this?
Sure. So this is a question we hear a lot. I think we come across a lot in early intervention, the question of head size. So we wanted to find out from you guys, what do you think about this? Do kids with autism have bigger heads? So you're going to answer this using your polling tool. So the polling feature is found, if you look, somebody dropped their pointer. I guess that's another way to do it. You can also put it in chat. We'll be creative today. You can use your poll by looking to the left of your slide. In the participant box where you see your name, look below your name. There's 4 small boxes. The box with the lowercase a is farthest to the right. If you click on or hover on that box with the lowercase a, you can access a drop-down menu of the ABCD choices and cast your vote. You just click on your choice, and then we'll be able to see it on screen in a moment. Or you can do like your colleagues, and you can use your pointer tool. That's another way to do it. So I'm going to pause and give you guys a chance to cast your votes, and then we will see it on screen. So let me see how everybody's doing. I love it that you guys jumped right in with your pointer. Let's see. All right, Jeannie, do you mind publishing the poll? Looks like on screen we have a mixture of answers for C and D. And then in the poll we have, looks like most people put D, but again, a mixture between A, B, and C. So Dr. Harrington, you want to fill them in on the answer?
So I'm going to fill you in by sort of showing you another slide. So it's actually everybody's right no matter what they put, because it does depend. So in the sense, D is correct answer, so I'm just sort of throwing that out there. But there was a lot of research done related to this rapid growth of brain. So if you look at this slide, on the y-axis, you're looking at the size of the head, and on the x-axis, you're looking over time, okay? So at birth, it was noted that some kids with autism who were diagnosed afterwards had a smaller head. But progressively at 3, 5 months to 12 months to 6, their heads grew quickly and overarchingly got bigger. However, this was sort of if you have to look at things longitudinally. So if you look over time, you would find out that these kids not only sort of grew quickly, but then they stopped growing once they got to a certain age. So therefore, initially there was a greater volume, but there was no pruning of the synapses in the brain. So your synapses are really important. It's sort of like thinking in terms of if you know how to get to Virginia Beach and you live in Chesapeake, you can take the back roads and go to, down 58. You can take, different ways, and you can learn these other ways. But if you really want to get there fast, you can take the highway. But if there's an accident on the highway, then you're going to have to go back out on the regular local roads and take a little more time. The issue with tracks and the issue with synapses is that you want to take the fastest route to the answer that you're trying to get to. So with synapses, we prune them on a regular basis in our brains as we're growing. Otherwise, we have these useless roads that lead to nowhere. And so in kids with autism, we were realizing that their synapses there were too many of them, and they weren't being pruned. And so kids with autism were having larger heads. But over time, the pruning did happen, but they also lost cortical thickness, and they actually got smaller brains over time. So in that scenario, the kids over time developed, by age 15 or 16, their average brain size was the same as their siblings. So what you were seeing was this overgrowth and then undergrowth of the brain in the cortical cortex, which is really what was your thinking areas and stuff like that. So this is a critical element to understand that, yeah, their heads are growing faster, but if you're building something that's not correct, it's not going to work well. So you can have a very big brain, but it won't function well. So that's really what was occurring in these subset of children. Now, not all children with autism have this thing that occurs, but only some of them. So it was a subset of children. So that's why the answer to the question is it depends. If you're in a specific subset of children, you initially will have a big head. It will regress to the mean by the age 15. So I know that rhymes, so I love rhymes. So it grows quickly, but it regresses to the mean by age 15 is my little thing that I say during talks and stuff. So anyway, that's generally what the issue is. So everybody who tried that question, it was a tricky one, but I promise you it was not meant to be tricky. We can go to the next question that may help you a little bit. Based on your current knowledge, what parts of the brain might be affected in rapid growth? The gray matter, the white matter, or both, or neither?
So you guys can get creative again. You can use your pointer tool to drop it on the slide by your answer, or you can use the polling feature and cast your vote by looking in the participant box and casting your vote clicking on that lowercase a. You also have the chat, so let us know what you think about this one. It looks like we have some votes coming in. We'll give you a little bit of time to answer the question. Looks like answers are still coming in, so we'll wait a few more seconds. Nobody decided to use their pointer this time, huh? All right, Jeannie, could you publish the poll, please? Oh, somebody did. They took a leap and put their pointer on. All right, so it looks like we have most of our answers agree with the person in the pointer on the slide with both, and we have a couple people that thought it might have been gray matter.
So I think this is a great example of a lot of smart people answering questions, because even the 3 people that answered gray matter probably were listening to what I said, which is they're not pruning their synapses, and that's why the brain is growing quickly. And the synapses are in the gray matter. So that is totally true. But in all things important in the brain, obviously both areas of the brain can be affected. So the gray matter is being affected a little bit more than the white matter, but the white matter, which is basically your cortical thickness, that's related to the myelin sheath around them, was decreasing as they get older. So over time, it's both. At the beginning, it's the gray matter. At the middle, or in the older ages, it's the white matter. So it winds up being both. So I applaud everybody who answered, because they actually were correct in both areas, A and C. Because I think if you were listening to what I said about the pruning of synapses not occurring in the young age group, that would be the gray matter area and stuff. So this is a smart group, Dana. I'm sorry. I'm not really working too hard on this one because they already know everything.
Hey, we like to hear that. That's awesome.
So in this slide, prematurity. So I think prematurity is an excellent model for explaining why things about the brain are difficult and stuff. Because in prematurity, even a few weeks matters for brain size. The brain grows exponentially in the last month of life. Even in the last 2 months of life, you see extraordinary growth in the brain. And then in the first 2 years of life, again, you see extraordinary growth in the brain. And this growth occurs basically from inside out. So basically, there's this thing called the germinal matrix, which it's not to be confused with Keanu-Reeves and the Matrix and stuff. It's really, well, it could be, I guess. I took the blue pill. But anyway, so the issue is related to how quickly the brain grows. And so if you're developing a foundation for your house and you move that house 3 inches off center, and you build everything on top of that, you're going to have a house that's not stable. And so when you think about the brain and you think about prematurity, and if the premature brain is not completely formed, yet we now are sort of pushed into the outer atmosphere and told, okay, you have to function now when you're not really ready, then there can be problems that occur. And I think this is sort of one of those things where we have not completely, we've always had an increase in premature births for the last 20 years because people want to deliver their babies either C-section or whatever, and parents can't, sort of wait long enough, to get a tax deduction or, anyway. But it's one of these things where prematurity matters. So if there's even a mild history of prematurity, that should raise a red flag that there could be concern. So I just think, from an early interventionist standpoint, but also from, a medical standpoint, prematurity matters, and we should sort of really look at that in terms of how we view the brain and stuff. And so in terms of areas that are important in the brain, so we are not going to cover all these, and Dana told me already that we probably would have to maybe do another talk if people wanted to hear more about the specific areas of the brain that are important. But many of you may know that the amygdala is important in human emotion and memory, and that communicates directly with the hippocampus. And so we have these abilities to sort of talk and discuss our emotions even. Like, this is so specific to humans, and these areas developed probably later in the brain and stuff. But so that's why it's very interesting how, social beings that we are, that's why this is so important to know these areas and how they grow and what they do and stuff. The frontoinsular cortex is really where your cognitive information processing occurs, a very important area where our higher thought processes are and stuff. When we talk about fusiform gyrus has taken on a lot of information too, because it's related to facial recognition and discerning social intent. So when they've done a lot of functional MRIs, they've focused on this area when they want to show someone who's smiling, and is this person friendly or not friendly. And if you ask a person who doesn't have autism, they'll figure it out if the person is friendly. If they ask the person with autism, they're like, well, I don't know if they're smiling or if they're just happy or, what. So it's the intent or the social intent is not understood automatically and stuff. And the fusiform gyrus is sort of where we make those impressions or those ideas about how things function. And you can see that these are such the higher functioning areas that if you disrupt them from a premature standpoint and these areas can't form specifically, you can see how that would then impact your ability further down the road and as you get older. So in the first few years, you may still be able to develop language, but then why am I having trouble with communication? Why am I having trouble with social intent? Why am I having trouble with my cognitive processing? Why can't I do math as well as my next person? Why can't I read for understanding? Why can't I do these things? Why can't I communicate well? That's why these higher levels of areas of the brain that sort of probably develop later in life, and if they weren't set up correctly along the tracks and you weren't able to sort of overcome those tracks, that's where this happens. And that's for a later talk, but just very interesting and very, just touching on that very quickly. Our next aspect is a baby's brain at 35 weeks weighs only 2/3 of what it weighs at 39 to 40 weeks. So think about that. You're basically 2/3 of the way there, right? If someone said, well, I went to college, but I made it through the first 2.5 years, so I didn't really get a degree. Well, that's okay, but at the same time, I don't know if I want you taking care of, I don't know if I want you taking care of my child, right? So, in terms of finishing things and completing things, the brain is not finished growing, and therefore, if we're looking at a premature infant, you must understand that you're looking at something that only had 2/3 of a chance to develop, and now we put it through some stress, maybe a difficult delivery, maybe a difficult neonatal course. Maybe there was some hypoxia, maybe there was some injury, it's not noticed on the initial exam, and then the baby isn't talking at 2 years of age, and everybody wants to know why. And so it's one of these things where I think, not that we have to sort of say that's what it is, but it does allow you to sort of think that through and understand that prematurity does matter and stuff. And we're going through kind of like the surface view. Now we're going to go into the inside view, which is called the neurotransmitters. And so many of you may know what a neurotransmitter is. This question was posed, which one of these is not a neurotransmitter? So we're at the polling stage again, and I'm hoping that you guys are, yep.
You do. Yeah, there's the pointers and the polls, so the votes are coming in both ways, Dr. Harrington, so we'll give them a second to see we didn't want to test your brain too close to lunchtime, right? So this one was a little bit of an easy one.
I figured they'd be hyperglycemic right now if they were munching on their sandwiches and stuff.
Well, Jeannie, if you don't mind publishing the poll, because it looks like we've got some pretty good consensus across both ways of voting. That one was an easy one. There it is. So we've got D as our answer.
So yeah, so neurotransmitters, most of you are probably familiar with dopamine, serotonin, and norepinephrine. In terms of the synaptic function or synaptic transmission, it's pretty complex. And likely we will not go through all of this slide, but to understand that it's a lock and key theory. So when the synapse actually occurs and the synaptic vesicle releases the neurotransmitter into the synapse in the synaptic cleft, and it recognizes the receptors that are there and transmits the message, all within like 1/1,000,000th of a second, if you will. These things happen so quickly that they're almost not able to be timed and stuff because it's just such an instantaneous electrical impulse, essentially. And so the receptors that locks the transmitters and stuff just requires just such a process. It's almost like a symphony or an orchestra occurring. And if one sort of instrument is out of sync, it's going to make it not sound harmonious. So when you're talking about many pharmacological agents that we use are trying to either disrupt this process or change this process, most people know what like an SSRI or have heard of an SSRI, which means a selective serotonin reuptake inhibitor. And if you think about that, what's happening with a selective serotonin reuptake inhibitor is basically it's locking up all of these synapses because they can't be broken down. And so it constantly stimulates that receptor to keep firing in those areas and stuff. So for kids with depression or things like that where these synapses are somewhat small or they're probably not functioning as well, we want to stimulate them as much and stuff. But some people feel that that may actually cause a burnout of those synapses, and that might not be a good thing. So there's a lot of studies ongoing about, how early can you use medicine, and is that an okay thing to do? And I think that's where I sort of weigh on the side of we try to hold off on medicine on kids for as long as we can because we don't know 100% what we're doing to those synapses and how that affects them over time and stuff. And we may be getting some of that longitudinal information over time, but at this point in time, we don't have a lot of the answers to help us with. So I do think that that's an important aspect that most of us really think about it over time, and we don't sort of, we want to fix what's now, and so some kids get medicine kind of early in their careers, and I wonder if that's a good thing or not. And I try to hold off on any type of medications and stuff. So if you are with parents who are saying, do you think medicine might help my child, and they're only 2 years old or 3 years old, you should probably say consult your physician before probably trying something. That's probably not a bad idea, because I probably would say that most physicians would say, nah, I don't think so. So something to think about. So when we think of the typical person with autism, sometimes we have to go to an atypical person. So if anyone knows Temple Grandin, she's a very famous person. They've done an HBO special on Templeton, and she, actually gave some talks when I came here about 10, 12 years ago. And she's a wonderful person. She talks about having filing cabinets of information in her head where she can remember things and remember how to respond to someone if they're smiling, how to respond to someone if they're scowling, how to respond to someone. So she thinks of it as a way of responding based on what she sees. And what you're looking here right now is a control of the optic chiasm information going from the optic nerve to the occipital area and stuff. And you can see how her tracks that go there are much thicker. I mean, it's hard, it's not 100% easy to see on this, but you can see that she's got multiple tracks going that way. You can see these multiple red tracks, multiple red tracks, multiple red tracks, and a little bit wider and thicker than these blue tracks in a normal person. So what you're seeing is that she's repetitively used these tracks and built up these tracks so that they're like a superhighway for her. So in that sense, you get an idea of what might benefit kids who are having trouble remembering things or having trouble, doing things, and that what we do is we overcompensate, or they can overcompensate in certain areas of the brain and develop those tracks over time. And so I think that that's a nice sort of segue into what are the strategies and tools that we can use for kids with developmental delays, language delays, and autism. And so some of the strategies and tools that are well known are early intervention and stuff. And so that's why I think this becomes really the functional key of this talk, which is what can you do that will help the child who's not functioning well or having trouble with things. And so one of them is learning not to give up, right? So being gently insistent to get the child to a different track or to utilize that same track. Some people, talk about intensive behavioral therapy, and there are different modalities of that, but it's really the idea of using repetition and sort of giving the child time to process. So a lot of times we'll say, we'll talk to the child and we'll say something, but we don't give enough time for a response. Once you understand that these tracks may not be fully developed, they may have gotten off track, or they may be traveling along a local road versus a superhighway, they may not be able to come up with the answer within that 1.5 seconds that you're giving them. They may need 3 seconds or 5 seconds based on the availability of the track, or if the track has been diverted somehow. So remember that when you're sort of asking the child a question and they keep looking at you, looking like they're looking off in space, but they may be trying to develop that track and stuff. So I think that's an important aspect, in the repetition and the time to respond. Using multiple senses of the body for movement and learning. You learned about the somatosensory areas of the temporal lobe, and that we remember things based on if it's hot or cold or sharp. But kids with autism may have to repeat that a few times and can be dangerous at times. Like they didn't know that was going to be hot. How did they not know that? How could they not understand that was going to be a hot thing? And why did they take that chance to do it again? Or why did they jump off of that, that couch at that height? What were they thinking? Well, their frontal lobe's not completely developed. They weren't really thinking and stuff. And be flexible with the use of the strategies that you do with kids. You can see that some kids might benefit from pressure, but other kids might not like pressure. Some kids might benefit from didactics where you're right in front of them and getting great eye contact. Some of them may not like you right next to them. They may want you a little bit further away and stuff. And so being gently insistent. So what I always say in every talk that I give, I said, it's not the modality and it's not the therapy, it's the teacher. It's the person who is delivering the therapy is the real sort of wild card in this whole thing. So in a sense, you may be doing a special speech thing and got trained in special speech abilities and stuff like that, but if the child doesn't connect to you, if they're not connected in some way, either through a physical touch or through a certain setting in the room, or a music that's being played, or however you're going to set your mood and your senses and stuff like that for the child, then it may not work. So therefore, be flexible. Don't say, well, this is the way I do it. This is always the way I do it. It works 90% of the time. Well, what about the other 10% of the kids? So you might have to adjust things. It's not an us against them, right? It's what can I do for this child? What can I do different that's going to make this child functionally improve? And move on to the thing where there's rapid growth of their brain going on between 12 months to 2 years of age, where you could effectively change the course of a human life through early intervention. And I don't say that just to be trite. It's true. There is so much brain growth within that time period that you can change the outcome of a child. So I think don't take your jobs lightly. It's a huge difference that you can make in terms of language and in terms of social functioning and in terms of brain growth, in terms of synapses, in terms of tracks. If you take anything away from this talk, it's that you can affect those tracks, you can affect those areas dramatically within a time frame that is so microcosmic in our world, right? Most of us live to our 80s, believe it or not. But if we don't get the foundation correct and we're living on a skewed foundation for the rest of our lives, that ain't good news, right? You're going to have trouble through the rest out. So anyway, I just that's a shout out to you guys. Let's get into just the last bit of this. We're on our last little leg here. What are some of the new techniques that are out there? Now, some people have heard of Google Glass. I'm not sure if you've heard of this. There was a recent study related to the effects of a wearable digital intervention for improving socialization in children with autism. And so what they did was they had a bunch of these kids, I think it was about 25 kids wear this Google Glass and 25 kids that didn't. And what they showed was it improved their socialization over an 8-week period, 10-week period. And it was interesting because what happens is the information would functionally go back to them and let them know like the most likely impulse that the person was in front of them having, like were they happy, were they sad, were they listening to you, were they not listening to you, did you need to get their attention? And the Google Glass would actually give them information that would help them physically and prompt them into doing more things socially to get more communication out of the person with them. So it was kind of an interesting study. Maybe not something all of us could do or afford, but maybe a look into the future in terms of how we would do things. But I critically think it's important that I don't think this is the wave of the future. I think it's still the idea that there's a person, a human, a touch, a feel, an understanding, a social connection that even using something like this, a Google Glass, there still needs to be the person that connects to the child. And you can see that there is a person there that's connecting with the child. It wouldn't just be a computer image or a holograph of a person and stuff. So I think in terms of how we look at things and how we move things forward in terms of our development of therapies and our terms of development of utilization and developing socialization in kids with language functioning problems or autism, I think the key is still the human touch and the human connection that everybody in this talk, who I think is on this talk, probably provides through their services and stuff like that. So I'm going to end there, and I will probably take some questions and have my moderator help me answer them.
All right, thank you, Dr. Harrington. So yep, we have plenty of time today. If you guys have questions and you want to type them into chat, this is a great opportunity, to post your questions. We did have a comment from Norfolk's, from Norfolk's program. They said all these children in the study were receiving ABA services. Is that the case, Dr. Harrington?
Many of them probably, like they did a review of it, and basically they were receiving some intensive behavioral services. I don't know if all of them were receiving ABA services, but they were receiving some intensive services. So I don't know if it was just ABA. It could have been TEACH or one of the other ones. They don't sort of comment that in the study.
Okay, and if you guys are interested in the link that was on the slide, you're welcome to email me after today and I could send you that link if that's something that you're interested in. We're happy to do that, or maybe we can snatch up the link, see if I can do that, and I can paste it in the chat for you in case you want to learn more. Well, Dr. Harrington, as we're waiting for questions, I want to tell you how valuable it is to hear a physician talk about the value of early intervention. I think your message about the importance of what we can do and the impact it can have is a really nice thing for us to hear, because as you know, it's hard work. So it's nice to be reminded that taking what we know and sharing it with families, and then helping families be able to use those strategies with their children between visits. I mean, it's a great possibility for some positive impact. So thank you for sharing that with us. It's a nice message to leave with.
Yep.
We do have a question. what are some good resources to share this type of information with families? So do you have any resources that you like, Dr. Harrington, or maybe that you recommend to families to help them understand the brain?
So there are a lot of sort of set things that you can sort of talk about. It's really, you have to know where the family members are. I mean, sometimes depending on getting them into information, a lot of times if you start Googling or you start sort of moving through this information, probably the best information is on sort of the websites that are how shall I say, scientifically validated. And so what happens a lot of times is parents start looking stuff up, and then they get into the wormhole of here's a therapy to increase your brain activity, and it's just another sort of kind of thing for a medication or for a what I call a nutrient that will help your brain function better and stuff like that. And it may just be a kind of a get-rich-quick item for the person who's trying to sell something. So it's hard to sort of lead parents in the right direction. I think there's a lot of good information that can just be garnered through PubMed and just looking at the brain and the functioning. There's a lot of research on the genetics in the brain, and so those are areas that are that have a lot of information and stuff like that. It's very hard to get, and that's why I was preparing for this talk and it made me a little bit nervous. There's not a lot of good information on just the nuts and bolts of brain function in kids. There were the studies by Eric Korshine about the head size and stuff, and those have all been kind of poo-pooed. And then there was stuff related to what we call microcolumns and stuff like that. And a lot of this gets a little deep and a little difficult for parents to kind of wrap their hands around. I think the most important thing is sort of what I just said, is sort of telling them that you can train the brain to be flexible, and the brain has flexibility throughout its entire life. And so therefore, if you have any problems at age 1 and it's still there at age 2, it doesn't mean that it's over and done with. There's still flexibility in the brain. And so the studies that have been showing about tracts and changes in development of tracts and the functional MRIs and things like that that are now coming out and stuff really show that you can develop different avenues of brain growth over time. And so I think you can still challenge the brain to learn. And this is true of adults, and I think that's where some of the literature is now leading towards teaching adults new things and stuff like that to diminish dementia. Because the other issue with autism is some people believe that it mirrors dementia, so that if you can learn how to functionally keep the brain occupied, it doesn't have a chance to go into a dementia mode. So that's why some people are saying, learn a new language, develop a new skill, pick up a new instrument, try and learn something, because you will develop that area of the brain, and that area of the brain won't develop dementia. So in an interesting sidelight, a lot of the new information is really related to adults worried about developing dementia and how to stop that or forestall that in that. So I think that's another kind of thinking in terms of we are not the only people, meaning kids and early childhood, they're not the only ones that are worried about their brains. It's older people now. The baby boomers are getting older, and they're sort of like, well, I don't want to have dementia. How can I stop that and stuff? And these two areas of research are merging now in how to prevent or how to treat autism, but also how to prevent dementia. And so some people have been using medicines that have been for dementia for kids with autism. So that's another story that we could go into in terms of receptors and stuff like that. But I think it's a really important aspect. I don't have a specific source to send parents. I just talk to them about it. There's not a lot of good sources. One of the ones that I do talk about is the neurobiology of autism. Margaret Bauman, who did most of her career looking at children's autopsies Her name is Margaret Bauman, B-A-U-M-A-N. She basically researched that for 40 or 50 years of her career, and it's basically looking at autopsies of brains of children with autism and sort of citing her findings and then making some predictions about what they would find clinically and being right half the time. So, so a lot of the information that I garnered when I was first learning about this was through Margaret Bauman and meeting her and stuff like that. So a pretty interesting read, if you wish, her Neurobiology of Autism. But in terms of just learning stuff, there are stuff out there, but I would stick to the published in public journals versus just going to websites that have information related to the next new drug that's out there.
Okay, great. Thank you. We've got a couple of other questions. We have a comment from Fairfax where it sounds like they would like to dig deeper. They'd love more information about brain functioning differences in kids with different diagnoses, so that might be something for us to keep in mind for next year. That's a great suggestion. We have a question. Fairfax asks, is this how you explain an ASD diagnosis to families who are trying to understand what causes autism?
Yeah, I think in terms of causing autism is a neurodevelopmental disorder. It has strong genetic basis and strong environmental bases. So what we know is that the environment that is prenatal and postnatal have an effect on the development of autism, and so therefore your prenatal environment can sometimes dictate what's going on postnatally, but there's probably some postnatal issues that are also there. So from a brain standpoint, again, higher degrees of autism in kids with prematurity, higher degrees of autism in kids that are twins, higher degrees of autism in kids that have any type of insult during prenatal care. Higher degrees of autism in kids with early language problems and stuff. So there's all of these aspects that are related to the brain function early on, and that as we move forward and look at the brain, it just gets compounded. And so from the standpoint, how do you explain autism to families who are trying to understand the causes of autism? Really I tell them it's not their fault, like it's not the parental fault, but it is a fault of neurodevelopment. So we're not 100% sure what causes these problems. We do know that there are more kids with autism, but we don't know why. And there are still some theoreticals out there. It does not appear to be from vaccines because those are postnatal insults. They're not really insults, but postnatally. But it seems like kids who get vaccines are less likely to have autism, so it doesn't make sense either. And so therefore, we're not going to put it off to anything specific. Kids do use cell phones now early. Kids are exposed to more radiation because of cell phones. They're exposed to more because of microwaves. I mean, there's a whole bunch of different things that people have been trying to sort of put together to say this is why, or this could be the reason why. And the idea is it's probably multifactorial. There's probably not one thing that's causing this and stuff. And there probably are abilities to prevent autism that we just don't know yet. We do know if you're healthy. We do know that if you go to full term, we do, those types of things. You have a good diet. You don't have your kids too close together. But there's been some studies like if you have kids every 9 months, that's not good because you're probably using up a lot of your reserves to feed the baby prenatally and stuff like that with your own body reserves and stuff. So there's studies like that really don't necessarily answer. They probably provide more questions than answers in terms of how to explain this to families. I just tell families, provide the best milieu, have a healthy diet before you get pregnant, continue a healthy diet afterwards, and and then do as much as you can with talking and interacting with your child as much as you can early on in life. Try not to plop them down in front of a TV or a screen, and be engaged with your child from day one. And outside of that, I can't think of anything else we can do differently at this point.
Well, I think that's great advice. I think, all the stuff you talked about, that could be a whole nother webinar, I think. So I see we're wrapping up. We've got about a minute left, but we have another question from Kelly Hill. And this one might be, I don't know if this is able to be answered in a minute, but it's a great question. So she's asking what your thoughts are on connections between brain anomalies and gut health. She says she sees so many problems with eating and digestion in babies and young children with neurological disorders.
Yeah, there's been a lot of work on neuropeptides or neurological issues concerned with gut issues and stuff, and there are some theoretical models out there that really have not been proven. The issue a lot of times with kids that have autism or early autism is that they usually do have limited diets, and then with the limited diet, they're more likely to have some GI problems. So it's kind of like an chicken and egg theory issue related to the GI problems leading to the neurological problems and stuff. Anytime that you're not eating well probably doesn't allow you to function well and stuff. And it may be a true and unrelated thing where kids who have GI issues also have autism, but it may be that they're so selective in their eating habits or that they avoid certain foods that may be more gut healthy that they just don't seem to improve on certain aspects and stuff. So it is, it's an excellent question and one that is in search of an answer, but we really don't have great answers for it. We do see a lot of issues, but I see a lot of kids with autism who have absolutely normal diets, who have absolutely normal GI health and stuff like that. There's been lots of reports, 80% of kids with autism have either constipation or diarrhea or both, and that's true. But if you ask, if I asked kids who are between the ages of 2 and 4 if they have constipation or diarrhea, almost half of them, the parents will say that too. So it's sort of like, yeah, almost 50, and this is the real studies, 50% of kids say that they have problems with their GI tract anyway. So if it's a 20% higher rate of kids because the parents are focusing on it, then it seems like it's much more likely. But because the child has autism, we're more likely to talk about it because functionally that's a problem, right? If they're constipated or they're irritable or they're acting out and stuff like that, we worry about that constipation and the diarrhea. Whereas if they're normal functioning and they have diarrhea and constipation, we just say, oh, they're just irregular or they're not having a good day today. But they're not having meltdowns, right? So it's just a different way of viewing that and stuff. And I think a lot of times we kind of it's a misnomer to say that all kids with autism have GI problems and stuff. So it's probably just more related to the fact that they also have autism and now they also have GI problems and stuff. So I think we're seeing that generally.
All right, thank you, Dr. Harrington. Well, I'm looking at our time. It's I have 1:02 on my clock, so I'm going to wrap us up. I do see that Crater has another question, and folks from Crater, if you want to email me your question, then I can follow up with Dr. Harrington and see if I can get that answer for you. But I want to thank you guys for joining us today. I think you got a lot of food for thought. I know there's a lot to think about in all this great information. I do want to remind you that after today, you will get a survey by email. The email, you'll get the survey link. We ask you to complete the survey to give us feedback on today's webinar. Once you complete the survey, you'll have access to your certificate of completion. For those of you that are joining in a group and maybe one person registered, when that person gets the email, you're welcome to circulate that survey link to your colleagues who participated in the webinar so they can provide feedback and get their certificates as well. The webinar will also be archived on our website, the Virginia Early Intervention Professional Development Center, so you can look on the 2019 Talks on Tuesday page, and that should be up probably within the next week or two. So again, we're having this is our last webinar before our summer break, so we won't have a Talks on Tuesday in July and August, but we will see you guys hopefully again in September when we resume our webinars, and we'll be talking about early childhood mental health. So thanks, guys, for joining us, and thanks so much, Dr. Harrington, for presenting for us today. We really appreciate it. You guys have a wonderful rest of your day and a great summer, and hopefully we'll see you back online in September. Bye-bye.
Thanks.
Bye-bye.